joining in, and I still see that the numbers are going up and people are. I see that there's still more people coming in, but let's just start so we can keep up with our time. So again, Assalamu alaikum everyone, and welcome. Good morning, good evening, good afternoon, depending on where you are joining from. My name is Sarfraz Hasni, and I am a physician scientist and clinical researcher, director of lupus research at the National Institutes of Health in Bethesda, Maryland. And you are joining the webinar series, which we do every 2 weeks under the auspices of APPNA, which is Association of Pakistani Physicians of North American Origin. And this is the MERIT subcommittee, which is Medical Education, Research, International Training, and Transfers of Technology. So under this APPNA MERIT subcommittee webinar series, we've been doing it for over 2 years now. Every 2 weeks, we have a different researcher coming in and sharing their experiences and trying to establish some flow of knowledge between both ways. So we are learning and people joining are learning. Today I'm joined with our panelists back again. In the panelist chair is Dr. Sayed Uzair, and he was missed for last 2 weeks, but we are happy that he's back and in the driving seat again. So welcome back, Dr. Sayed Uzair. And of course, our Dr. Umar Hayat is here. He's always, guiding us and then providing some words of wisdom, and one of the panelists here. And then our speaker today is Dr. JABEEN FAYYAZ, which I think people who join us regularly are probably already familiar with. But just a brief intro of Dr. FAYYAZ is that she is a associate professor at University of Toronto, and she has joined us in 2016 as a fellow, and now she became a staff physician. Previously, she was a faculty at Aachen University for 5 years, and she is one of the few leaders in Pakistan with EM specialty recognized by the College of Physicians and Surgeons. Subsequently, she was also at Sultan Qaboos University Hospital in Oman for 3 years, and she did a implementation of the Canadian triage and acuity scale. So at the sick kids at Toronto, she has been instrumental in terms of establishing the sim lab or simulation lab, and she has done a lot of collaborations with in places in Pakistan and conducts several sessions with the medical students there also, and has been very active in terms of research and medical education, and among multiple different things. And she has been a regular at the APPNA MERIT webinar series. So with that brief intro, before I hand it over to Dr. JABEEN FAYYAZ, I just wanted to acknowledge Waleed and his team, who are working behind the scenes and make sure that all of these webinars are conducted smoothly. And not only that, they also make sure that the post-webinar, the YouTube, the post-webinar, the recordings are posted in YouTube in a very timely fashion. So if you have missed a part of it or you want to go back and listen to any of it, please go to the APPNA MERIT YouTube channel, and you have not only today's, but anything in the past that you have missed, you can go back and listen to. And last but not least is that you can join our digital library WhatsApp group, where Dr. Ozair has compiled multiple research resources, and these are all free. Whoever is interested in clinical research and trying to learn and do research, there's tons of resources available there. So please join that group, and you have all these resources at your disposal. So with that, I hand it over to Dr. JABEEN FAYYAZ. And again, thank you so much, Dr. FAYYAZ, for taking time. I know you're very busy, but we really appreciate that you have taken time out of your busy schedule. And with that, please take it away, and we'll go from there.
Thank you so much, Dr. Sarfraz, for your kind introduction. I'm really humbled. And thank you to the APPNA leadership for this initiative, and always organizing it so well. Are you able to see the screen? I think somehow it get paused. Let me try to share it again.
Yeah, we only see a blank screen before, but let's just see.
Yeah, I will share it again. And really, my focus while I'm sharing the screen is today to talk about how simulation can be utilized beyond the teaching and learning, and also beyond outside the sim centers. Simulation is not about always getting a sim space, getting big mannequins. There are so many things that can be done by using simulation, which is for quality improvement, patient safety. So that will be my kind of focus that I'm going to talk today, so that I can inspire some of you to think beyond teaching and learning when you are thinking of simulation. In my disclosure, I have been working at various leadership positions in these societies and some academies. Today, what I'm going to talk about, simulation and QI, some synergies, some myths to debunk, and then share case studies from my own clinical practice and some of the future direction. And those who might be joining today as a first time, I have taken a foundation, concepts of simulation 2 weeks ago. So it is kind of a build up on there. So might be it is a little bit of higher level concept, but I'm pretty sure you are going to take something out of today's presentation. So again, to revise, I said I defined the simulation last time as well, but just to reiterate that simulation is not about always technology. Simulation is a technique to replace or amplify real experiences with guided experiences that evoke or replicate substantial aspect of real world in a fully interactive manner. Like you have introduced PBLs in your students, or learning environment, case-based discussion, work-based education. Similarly, simulation-based education or learning is a pedagogy and a technique which people usually confuse as a technology. And then if we look at the quality improvement by Institute of Healthcare Improvement, quality improvement refer to systematic efforts aimed at enhancing processes and outcome within the healthcare systems and organization. So quality improvement is about continuously identifying areas where we can enhance our processes and outcomes, ensuring that we are providing the best care to our patients. So how the QI and simulation synergizes with each other? I would say QI and simulation work hands in hand to enhance healthcare outcomes by providing a safe environment to test and refine new processes and intervention. Simulation allows us to identify potential issues and implement changes in a controlled setting, while quality improvement principles ensure that these improvements are based on measurable outcome and continuous feedback. So how they matches to each other. Putting safety first. Both simulation and quality improvement put the safety first. Simulation allows us to train future practitioners without risking patient safety. It provides us safe and brave spaces to achieve proficiency in critical skills, similar to many industries like an aviation industry, the military training. They are all richly, they all have simulation very much all the time throughout their career. Second, both simulation and quality improvement or the clinical environment, we work to optimize the space and team. That errors which happen is the focus is on the human factors or human beings or we as a clinician, but it is very much shown in literature that if you want to improve the patient care, you have to focus more on system and design and implement system level changes in addition to the personnel's education. Also, simulation provide a valuable feedback and guidance loop. Feedback, we all know, is a critical component, not only in quality improvement in clinical work, but also simulation, providing immediate insight into the consequences of decisions and action. This real-time feedback helps participants recalibrate their performance, enhancing learning and engagement. And the last is integrating multiple skills. Simulation provides unique platform to integrate both technical and non-technical skills. You can do interprofessional simulation with all the team members working together, understanding each other's role, and then improve collaboration. It allows healthcare professionals to practice clinical procedures, but also honing on to their communication, teamwork, and decision-making abilities. This holistic approach ensures that all aspects of patient care are addressed, leading to more effective and cohesive healthcare delivery. So if we look at the current landscape of quality improvement and the clinical teams and the simulation educator, they're working in parallel or a distant silos. Although they both have an intention to improve education and learning, to make the clinical environment conducive or ready to patient care, they both want to look at the system design thinking and incorporate technology. But then what happened, despite of their shared goal of enhancing healthcare outcomes, there's a lack of structured feedback loop between quality improvement, clinical environment, and simulation. And this separation means that valuable insight from simulation aren't systematically used to inform QI initiative, and conversely. QI findings aren't consistently integrated into training through simulation. So bridging this gap is a need of the time. So rather than working in parallel, integration and collaboration between these teams is the need of the time. By working together, what we can do, we can develop more effective strategies and drive more meaningful and visible changes in our healthcare practice. So what it will do, it will create a continuous loop between teaching and learning, informing clinical environment, quality improvement, and then we will move from our present situation to ideal situation, which is through working together. With this preamble, I want to debunk two important myths about simulation-based activities. First, simulation is costly and resource intense. Yes, it is costly, but then if we look at the cost of failure, cost of error, is it still more? Simulation will require some initial investment in terms of faculty development, in terms of resources, in terms of space development or equipment, but in the long run, on a sustainability perspective, there's a much more return of investment than the medical errors who is posing to our healthcare environments. So one of such initiative is an example, Helping Baby Breathe, which is a well-known global initiative by WHO. And up till now, Helping Baby Breathes is introduced over 80 countries with 450,000 birth attendants trained and equipped by a very, very low fidelity mannequins. It's just a doll which can be filled out by an air and water. And what difference it has made. It has improved the neonatal mortality by up to 50% and misclassification of fresh stillborn by up to 25%, which is a huge impact and a huge benefit. Second is our work with Indus Hospital Health Network, which I might have shown in other quorum as well, but I just want to mention that Pakistani healthcare simulation, we always say, okay, it started with me and Saima, who is my class fellow and who become the head of the department of Indus Hospital, and Adil Khatri, who was the program director. So we just started 2 or 3 people and log milte gaye and karwa banta gaya kind of thing happened. This is the kind of team which I was working, and what we did, we really work on Jugaad. And what is Jugaad? It is a local context, low cost effective mannequins that are equipment that we created to create realism in a simulation based learning. And what happened, you can see simple kitchen items, simple hospital related items were used to create a defibrillator, to create a tracheostomy or cricothyroidotomy models, to create chest tube models from laundry basket, to create task trainers for birthing. Like you can see here, the lateral canthotomy model, which is just from a golf ball and a small plastic cups. The IO models were created. And then this one is a pajama model for providing birthing simulation. And then this is all simple cloth hanging clips through which an LP model was created. And then a loads of trauma-related mannequins, etc., were created. This is a cost-effective central line mannequin which was created, ultrasound guided, and tabletop exercises were done. And what does it yield? These are all the training programs conducted at various timelines. And then we also implemented a cost-effective innovation of online simulation using various platforms like virtual resuscitation room, affinity learning, full code applications, and then implemented a faculty development program for training the faculty member, as well as a foundation program in pediatric emergency medicine, which is a one-year certification program in pediatric emergency medicine. And these are some of the timelines. So what does we yield? We yield high satisfaction. It is relevant to their cultural context, and we provide them a safe, non-judgmental environment to learn. And what is our overall impact? Up till now, we have trained almost 500 IPE teams in basic emergency care, trauma care, pediatric emergency medicine, and SIM training as SIM instructor workshop to 68 faculty members in Pakistan, India, Saudi Arabia, and UK, with the help of 28 local and international facilitators from all over the world. With this impact, then we moved on to a project which is done in India, which is a national implementation of a trauma resuscitation management program. It was done last year in November, where like ATLS, which is Advanced Trauma Life Support, whose focus is mostly adult with only one chapter of pediatric trauma is present in that, we make a whole module of pediatric trauma resuscitation with the help of various local and international facilitators. This is the module which was all developed with all aspects of starting from airway, breathing, circulation, head and neck trauma, chest trauma, abdominal trauma, and the crisis resource management. And these are some of the pictures while I was there with other faculty members to do the training. And we were proud to say that we trained almost 71 faculty members, train the trainer, so that they can take this training to different parts of India and then improve the pediatric trauma care there. Then the third example is in Ireland, which is all again through virtual simulation, where we train the faculty to implement in situ simulation. And what is in situ simulation? It is not doing simulation in a big sim center or big resources to do simulation in any place available in your clinical environment. For example, your clinic, for example, your ED, for example, your lab, wherever you are working, doing simulation there. And we yield a lot of higher level feedback. And then most participants have no prior simulation experience. 3 simulation they were able to implement by this faculty development. I think we did 2 sessions where we trained 55 faculty members, which are interprofessional, and then they go back and they did simulation in situ about anaphylaxis, local anesthesia toxicity, and head trauma, and they were all successful and led to the identifying important safety and quality improvement issues. So as I said, yes, it is costly and resource intense, but once you have implemented, it will provide you a very good return of investment. The second myth is simulation is just for resident teaching and learning and not beyond that. So I would say there's a loads of data now available, which says that simulation is now utilized more and more for policy development, policy testing, for system and process testing, and for many, many more, which is now being labeled as translational simulation, where you translate the teaching and learning into actual clinical environment. And to give you an example from my own institute, we developed this code silver active attacker policy, where from the development of the policy, choosing words and involving the subject matters experts by tabletop exercises, we developed the whole process by using simulation. So simulation is not for only teaching and learning. Its utilization is much, much more beyond that. So just to continue the same thing, that simulation is more than teaching and learning, just give you a couple of more examples. So as I said earlier, team training in situs. So what is team training in situs? Team training in situs are simulation that are physically integrated into the clinical environment. And why it is important to do simulation in your actual clinical environment. Because deliberate practice and integration of teamwork skills in a time-pressured clinical environment provides great realism and is a rich source of identifying latent safety threat and system-based issues. So what are latent safety threats? Latent safety threats, as you can see in this picture, this banana peel is there. If nobody slipped through it, error does not happen. But if it continue to be there and nobody will take it off and put it into the dustbin, at any time, somebody will slip and have a fall. So similar is the concept that latent safety threats are conditions or factors within a system that have the potential to cause harm or compromise the patient's safety. So for example, in this picture, you can see the person is taking care of a small bear, but there's a bigger threat present behind him. So system-based threats to patient safety that can materialize at any time and are previously unrecognized by healthcare providers or administrator. And by doing simulation in situ, you can identify those threats. So what we do at SimKids, we have a team training in situ, which is implemented like a long back ago in 2014 by Jonathan Perry, who is my supervisor when I was doing a simulation fellowship, and now a colleague. We do 12 scenarios every week, 8 to 10 a.m. in the morning in our hospital environment, because this is not as busy environment. And our curriculum is based on the most common cases presentation, any mortality and morbidity cases, any safety threats that we identify, any new policies and procedures that got implemented. We have a checklist for the case, as well as we focus on the non-technical skills by using this team score, which is a validated checklist, and it focused on leadership, on teamwork, on task management. The second thing is clinical event debriefing. The clinical event debriefing is actually a process or structured, using a structured guideline to do debriefing after a critical event or emergency situation happened in healthcare. For example, in our department, if a patient come in and have an arrest, after dealing with that patient or managing this patient, once that patient get admitted or moved to ICU or whatever the disposition need to happen, we will sit together, talk about how did our team performed. So what is the advantage of acute event clinical debriefing? It is immediate. It involves multidisciplinary team. It is a structured process. It allows reflection and analysis of what learning happened in simulation to an actual environment, and it is very action oriented. This is the tool we use, and it has got 3 domains: teamwork, medical management, and system. And we just asked 3 questions. What went well so that we continue doing those aspects? What are the areas to improve, and what is team suggestions for improvement? So that the team feel involved and they will give us some ideas and some of the inner insight and reflection that how can we do perform better. Then all those themes or the latent safety threats which are identified, we utilize the SEEPS model, which is a systems engineering initiative for patient safety, to categorize these latent safety threats that help identify and analyze the various elements that influence the performance of individual team within a healthcare system. So what is the example? Let's take an example of our neonatal resuscitation process. We do not have a lot of neonatal resuscitation in our hospital, and we always think that our teams does not perform well. And when we start doing the clinical event debriefing and team training in situ, we find out that there is a much needed simulation in this area. So when we looked at the data of our neonatal resuscitation from 2018 to 2021, there are 26 neonatal resuscitation that happened. The neonatal team activation was done only in 38%, although 70% of the babies require resuscitation. When we looked our team training in situ data, the team scores, which is usually out of 10, we found out a low score of 6 to 7 for neonatal resuscitation, which was much, much higher for other clinical scenarios. And when we talk to the team, we find out there's a huge need for neonatal order set, neonatal activation pathway. There's a lot of medication errors were happening. People do not know when the neonatal team come in that they have joined. There's no transition of leadership. So what we did, we implemented some interventions. First one, which is on the left-hand side, we implemented stickers where they can place it so we know who is the ED team and who is the acute care transport or the NICU team, which is coming in the emergency department. Then we develop a neonatal order set. The third thing, the major thing which comes up is that our neonatal rapid response algorithm is not working. So what we did a small walkthrough simulation from start of EMS call till the neonatal activation. So these are small mini sims that we did in our ED in the morning shift, in the evening shift, in the night shift, on weekdays and weekend. And then we did a revised version of our algorithm, which moved from 3 steps of calling to only 1 step of calling with the consensus of ED team and neonatal team. And what happened? The neonatal activation time improved from 15 minutes to 2 minutes, and neonatal team arrival time reduced to only 3 minutes. And there's a very smooth transition of leadership. So this provides a big example of how our team training in situ using Mannequin have informed us some strategies, and then using those strategies, how we implemented in actual neonatal resuscitation when it is happening in our ED. The next example which I want to implement or highlight is CPR coach role. We noticed that while doing acute event clinical debriefing, the CPR quality, which is one of the most important predictor of cardiac arrest survival, is not good. So what we did, based on the literature and data, we implemented the CPR coach role using simulation, which is a simulation-based quality improvement led by one of my colleagues, Roger Correa, and this is the whole team which was involved. So what is a CPR coach? CPR coach is a resuscitation team member whose primary responsibility is to provide real-time coaching and feedback of CPR performance during cardiac arrest, thus allowing the team leader to focus on other component of advanced life support management. And it is equally important and equally beneficial in pediatric and adult. The CPR coach oversees the quality of chest compression and coordinate the timing of defibrillation and intubation to ensure minimal interruption in the compression. So it was, the whole training program was simulation based. There was a asynchronized online videos, like a virtual gaming simulation module, then in-person simulation training, followed by in-person simulation evaluation, which gave them a title of CPR coaches, and then a refresher, which is also simulation based, was offered at regular interval. So let's watch the CPR coach role video that we developed for them as a training video. I will skip a little bit part of it and then start from here. This is the scenario which is provided to them, and then we highlighted some of the coaches. I'm JABEEN. I'm the team lead. Can you please check the pulse and rhythm for me?
We don't have a, I don't feel a pulse.
Okay, because we don't have a pulse, let's start high quality CPR.
1 and 2.
I'm going to get you to compress and count out to 15, and then we'll do 2 breaths.
11, 12.
My name is Bhavin, I'm the CPR coach.
1, 2.
If we could get a backboard and as well get the pads on to help to optimize high quality CPR.
Hi, my name is Alora. I'm the medication nurse. I gotta get the pads.
So we created this kind of videos and then trained all our CPR coaches. This is our physician assistant group who were trained as a CPR coaches. It yielded a high satisfaction. You can see the scores are in 4.95 to 4.85 in all the domains for the online training and in-person training. And our QI parameters like the quality of CPR, the rate, depth, etc. will get better also. But did we stop here? No, our improvement and monitoring continue. So first is CPR flare workflow. So what happened, our CPR coaches are not present always in one area of the ED. And our ED has an East area, West area, and a hub and surge area. And the CPR coaches can be working in any of this area. So how do they know that a CPR is happening so that they can join the CPR? So we have a Amber Alert in Canada. Dr. Uzair and Sarfraz and Dr. Umar will be aware of that we have an Amber Alert of emergency, which beeped on our phone. So using the similar concept, we utilize or we created an Amber Alert for CPR coaches. So if CPR happens, this kind of Amber Alert and a red will appear on a red thing appear on the screen, and the CPR coaches will know CPR is happening and they will join the CPR. The second is in a recent event where there is a child who had an arrest, and we found that the Zoll monitor is not providing us the correct reading. It is saying the depth is very, very high. So what we did, we create a working group including the ED Resuscitation Oversight Committee of the hospital, of the ED, the QI representative, and a Zoll representative. And we looked at all the anecdotal possibilities that can create error. And then we run a simulation testing by recreating all those possibilities and to see what is working, what is not working. And based on that, we come up for the recommendations for our CPR coaches that what they will do if that kind of reading is showing up on the Zoll defibrillator. So this is kind of a continuous process of, or I would say a loop of communication, which is informing simulation, what to do, what to test, and simulation informing the clinical areas and clinical environment and clinical leaders that where should they focus. With this, what is our future direction? So I would talk about these three things: augmented reality, chatbot, and escape room. Augmented reality. So if you're wondering what is augmented reality, so augmented reality is a type of virtual reality that overlays the virtual images on the top of the user's actual physical world. For example, in the leftmost first picture, you can see a lane, which is an actual lane. But when you are seeing it from your phone, it has highlighted where is the hotel, where is the ATM, where is the parking. Similarly, for example, in the second middle picture, how it can be relating to the healthcare environment. You are doing a CPR on a mannequin, but through your glasses, you are seeing the anatomy of the heart. And when you are doing the CPR, you are seeing how the blood is getting pumped from heart to the brain. So this is what now it is getting into more and more, and it is like a real-time road traffic or like a great data or traffic survey where there's an actual environment and the augmented reality and AI is showing what is the pedestrian, what are the ships, there are the different things, and it is showing which things they are moving. So what we are doing, we are working with Johns Hopkins Hospital in a big grant, which I'm going to show you, for using augmented reality glasses for CPR feedback. So this is the grant, which is the PIR from Johns Hopkins Hospital, and our SimKids is one of the site investigation site where the augmented reality glasses will be used, and you will see the person who is doing the CPR will see feedback on their glasses, and it will guide you when to start compression. And if it is good, you will see all parameters are green. But if you're going too fast, it will tell you that your compression per minute is 127 and you are going too fast, so go slower. So it will be a plan to happen next year, and we will be very soon sharing the data, what we found, and how the technology can be used to leverage simulation, leverage quality improvement principles, and get translated to quality improvement and patient safety. The next is now the literature is full of chatbots virtual patients, where the learners, residents, medical students can interact with these virtual patients, can take the history, and then these virtual patients will provide you feedback. Let's see, this is PCS is one of the website. I do not have any monetary or any affiliation. I'm just showing because it's available and it's able to provide you that feedback. So this is the website look like. You have virtual patient. It will tell you, welcome to the patient file, give you a preamble, show you the vital signs, also show you all of your interaction. And this is one, watch this.
Hi Mark, how can I help you today?
Example.
I have this ulcer on the bottom of my left foot. It's quite sore.
How long has it been there for?
It's been there for a few days now.
Is there anything else that you're concerned about?
This is a bit embarrassing, but I have noticed that I need to pass urine more frequently.
How often do you need to go to the bathroom?
So this is an example, and then it will provide you the whole feedback. How was your history taking? Have you covered all the important aspect? How empathetic you are? What does your communication look like? Like it's a whole half an hour interaction with a 15-minute feedback. So which is amazing. And it is not far away that we are going to see more and more of this. The third thing which I want to share is escape rooms. So escape rooms are coming more and more, and this is kind of an example of a infection control education using escape room, where to improve the nursing approach or interprofessional approach to hygiene control and infectious disease. And it is becoming more and more into fashion, I would say, to learn by utilizing escape rooms, because our learners are 20th, 21st century learners, and they will not like to be taught, or they want some more ways or interesting ways of learning. And we are also creating a quality improvement and patient safety escape room using an immersive technology in our institute as well. Again, I would like to share this barcode with you all, that if you want to share or stay connected, not share, stay connected, follow our LinkedIn page for SimKids, and you are going to get all these updates. So in the end, what I want to conclude is just one thing, that simulation and quality improvement go hand by hand. There's a huge synergy between having quality improvement processes, also improving the care that you provide in your clinical environment, and simulation that can enhance each phase of your clinical care. So integrating into institutional quality improvement culture by rethinking purpose and process is the need of the time. And with this, these are some of my references. I want to thank you all for your patience listening, and I will share my email address. Please feel free to reach out to me for more information that you want, because I just passed away or giving you a 20,000 high fit overview of what things are happening, what are the possibilities. And I'm pretty sure that there are few things which give you an idea, and there are few things you want to learn more. But I'm always here and always happy to provide you more insight about any of the project. Thank you so much, everyone. I'm happy to take questions or any comments by the team.
Okay, thank you so much again, Dr. JABEEN FAYYAZ, for an excellent presentation. And I see that there's a lot of excitement and a lot of people have joined. I think we're gonna get few comments from our panelists, Dr. Zaid, Dr. Umar Hayat, and I see Dr. Sarwat Hussain has also joined. A brief comments from all three of them, and then Dr. Zaid, you can take the questions from the participants. Thank you again, Dr. JABEEN.
Thank you very much, Dr. Sarfraz. And thank you very much, Dr. JABEEN. Pakistan is proud of you. You are the shining star of Pakistan. And selflessly, you have devoted yourself to for the furthering of education, and particularly the medical education. I'm really amazed. It's like watching a fiction movie, with augmented reality and whatnot. Dr. Sarwat just missed the first part of the movie, so he has to build his imagination really to enjoy that part. But I think you have devoted yourself, wholeheartedly to promote this idea, and it is so convincing. When I look back when we were student, and maybe Dr. Sarwat was student, the soft skill and the technologies, they were not there at all really to help in any way to understand and improve the medical education. And this is an art, knowing something is something different, and communicating and sharing that thing in a very simple way, that is the next step. And you are the champion of both of these things. So full of praise, everything.
Thank you.
I have just a comment. The comment is because you spent so much time, so powerful presentation for 2 sessions, that maybe we can have some small certificate course, maybe to update the knowledge of physician or the teacher back in Pakistan. So maybe we can record it, asynchronous recording or something, which is a very, very small brief. So sitting over there, they can have some taste and they can have some direction, because it's amazing the way the things improved. You mentioned from 15 minutes to 2 minutes. It's a dramatic change, in neonatal resuscitation. So this is amazing, and I know every second counts in that. It's not the minutes, it's the second which is going to count. So it's mind-boggling, all the activities. And I will go to the question. Let's have some comment, Dr. Sarwat, and then
Ji,
Dr.
Assalamu alaikum ji. Thank you very much. Actually, I joined at 12th minute of the lecture from my computer, and then I now switched to my phone. So once again, amazing. I mean, Dr. JABEEN, last time she did the simulation lecture and this, and this is amazing, really. The couple, three things. Number one, I like the jugaad part, although in our society jugaad is a negative connotation, but jugaad is extremely important for low and middle income countries to get the same results that the advanced countries get with thousands and hundreds of thousands of dollars. So I like that. And in fact, I was talking with a colleague of mine today, is to write a book on jugards of intervention radiology. And we might do that, doing intervention radiology using what is available in a district general hospital. The other important, very important part is that there is a huge bridge between the West and the East, or between the high and the low income country, and that is technology. Previously, everything required a lot of money to produce a body of knowledge for teaching. Now, with the chatbots, with artificial intelligence, with all that the Dr. Saiba has demonstrated, it is within the reach of all of us to create the programs that will that will have tremendous effect. So my salutes to Dr. Saiba, and if I had a Tamgai Khidmat or Tamgai distinction, I would award her virtually at least. Thank you very much indeed. Appreciate that. Very, very good indeed.
Thank you so much. I'm really very humbled.
Yeah, Dr. Sarwat, you are yourself a legend in medical history. You know, you are the founder, chairman of Aga Khan Radiology Department, King Faisal, and whatnot. So you are a living legend by yourself. And these words and these compliments, they matter a lot, really. Genuinely, you pass a very genuine comments.
Sir, I only have white hair, that's all.
Because, and I could see the reaction from the participant. We will go to that. Dr. Umar, you know, it's over to you. Please, what would you like to share?
No, thank you very much. Wonderful presentation, very engaging, I will say. And log milte ge karma banta ge. I think this is very strong statement. And exactly that's what we are doing, and that's what every one of us should do. Initiate what you believe in, the success will be there. Other thing, the jugaad, I mean, look from the jugaad to the CPR glasses. I mean, how far you have gone. That shows the creativity. So the creative minds will always bring something into practice. And you know, those simulations in terms of saving the times, especially for the patients when they are, you guys are dealing with the emergency, amazing, fantastic. And I will say the Tagmai Jurat, Tagmai creativity, all awarded to you, by the way. And they are much better than those Tara Imtiaz, I will tell you.
Thank you so much. I'm really very humbled, and really I am doing the first cohort of healthcare simulation certificate course already with the University of Lahore, and we are the badge is graduating in August. So I am doing that. I have already started. So definitely this forum can be utilized to further disseminate and to further take it forward. Like there's always one step we can take forward, which can bring a huge impact and a huge change, in my opinion. मुझे लगता है कि हर चीज है, बस एक स्टेप लेने की दूरी पर है.
Thank you very much, Dr. Umar and JABEEN. And maybe we can co-brand your certificate with some Canadian institution that we can look into, and I think that will give much more meaning from the North America.
Yes.
Now moving to the questions. So the first question is from Sabine Khan. Kindly give example of any local QI project done for patient safety in Pakistan apart from education and training. Over to you.
Thank you, Sabine. It is a very, very good question. First of all, अगर आप देखो ना simulation को quality improvement के लिए use करने के लिए, you need to have first the foundational element. And I think in the last 4 years, I am, alhamdulillah, successful in training the faculty, in training the learners. And now what we are doing, we are actually looking at the patient level outcomes कि जो हमने teaching की है उसमें simple एक septic shock, which is a very, very common presentation in Pakistan, that when learners who have gone through, what is now the impact for is what is the time to fluid, time to identification, time to epinephrine. So the project is ongoing. There's no data yet that have been there, but from teaching them, the residents and the faculty member. Now we are in the process of implementing team training in situ, and by after team training in situ is the next step is to look at the patient level outcome. So this is one of the example that I can give to you, but I would say that require a lot of foundational knowledge. So that is why it is not right now okay कोई बहुत concrete project है, but there are things in the pipeline. If that make any sense for you, Sabine.
Thank you, Dr. Jabeen and Sabeen both. And now the next question is from Muhammad Shabir. Excellent, strongly requesting for some fellowship program to be started. So I know you have a fellowship program with the University of Toronto and SimKids Hospital. So maybe as you mentioned with the University of Lahore, you are also offering some activities. And I know you have been so much engaging in Pakistan with Indus Hospital and many more groups. Definitely, I think we can move in that direction, which is in a more central way. I have something in my mind and I will share with you about that. But I think this is something which is very much required. There is a willingness from Pakistani people and the professionals, and and you are willing to really take the lead. So I think we can do that. Now move on to the third question that is from Ms. Samina Malik. Is PCS a free AI tool? It can surely help in learning of medical student. Can we feed new information in it?
And no, Samina, it's not a free tool, but like I do not have any doubt. I'm in talk with couple of groups in Pakistan as well as in India to work on a low cost solution. Chatbot banana अब कोई भी बहुत मुश्किल काम नहीं है. It's become much more easier now than before. So stay tuned. Probably in some next few months or maybe a year, I will come up with a local low cost solution.
And by the way, you know, there is a group in Pakistan. They participated in APPNA and they may be offering free bot services for medical. It's a leading company. So in the sideline, we can discuss about that
Perfect.
with the Samina. Now, the next question is from Yasmin Hasnan. Hi, I have been involved in using SIM in medical education, plus tabletop exercises in MI planning and quality improvement in the UK since 2003. No doubt has made a significant difference. I'll be interested to know what, in your opinion, are the disadvantages of medical simulation and use of augmented reality. Thanks. So that's the other side of the table. That's very interesting. So what's the
Yeah.
downside?
Yes, that is a very, very good question. I would say que not to be get more entangled or get focused from the shiny things. Like what I noticed, ke simulation is all about a big sim lab and a high technology and a costly mannequin and this virtual reality, augmented reality. I would say ke it's so easy कि हम उस सब में गुम होके हम हर चीज में simulation को solution ढूंढ रहे हैं. Simulation is a solution to many, many things, but it would not be the right thing to do for everything. For example, if we are able to do a lot of in situ simulation and we have space to conduct in-person simulation, then using virtual reality for a lot of these education is not a meaningful option because it is very costly, it is resource intense, and the impact is not as much as you can create by using other pedagogies. Simple ये है कि अगर आपको lumbar puncture सिखाना है तो आप सिर्फ टास्क ट्रेनर पर लंबर पंक्चर सिखाएं, आप उतना ही सिमुलेशन यूज करें. उसके लिए आपको वर्चुअल रियलिटी, आई हैव सीन एनेस्थीसिया पीपल हैव क्रिएटेड अ virtual reality airway skill simulation where learners are going and by using virtual reality they are intubating a difficult mannequin, but they are not learning anything, they are just learning a knowledge part. So it's just such a waste of that high resource and high cost, जबकि वो आप बिल्कुल low resource में सीख सकते थे. लेकिन अगर आपका intention है कि आप team work develop करें, आप family communication develop करें, आप how to coordinate with your interprofessional team, then probably using the whole team simulation with the whole mannequin will be a meaningful answer. So the pitfall is to find simulation and technology as the answer for everything and spending a lot of money without keeping in mind कि आपका outcome क्या है और end goal क्या है. So I would encourage people thinking about the backward design of curriculum development for a lot of simulation-based learning activities to find out a gap and bridge that gap by simulation, not replace all your educational activities with simulation. So this would be my suggestion, and that is the biggest advantage of having simulation, because वो जो new shiny चीजें हैं वो हमेशा बहुत attract करती हैं.
Okay, thank you very much. That remind me, if you go and attend many of the medical sessions, the medical conferences, and only the speaker, they are sitting in the audience, generally the people are leaving, and this is so gluing and so absorbing session. The people, they continued their present till the question. So that is another litmus test, really, the power of communication and the time management and everything. Brilliant, super brilliant. I think we are moving towards the end of this session. Now I will hand over the session to Sarfraz Hasni for the final remarks and vote of thanks to the speaker and the participant and the technical team. So with this, thank you very much from my side and goodbye. Yes, over to you, Sarfraz.
Okay, thank you so much, Dr. Zair, for being the panelist and the driving force behind this, and Dr. Umar Hayat and Dr. Sarwat Hussain for your insightful comments and always being present for these webinars. And again, a big, huge thank to Dr. JABEEN FAYYAZ, who's doing a tremendous work and a niche work, which I think is something which is very helpful and have tangible results for medical education and for developing the human resources, human capital, which is very important, these technical skills. So thank you, Dr. JABEEN FAYYAZ, for taking time out of your busy schedule. And again, Waleed and his team always there supporting the technical aspects and making sure that everything is going smoothly. And a lot of people don't know, but there's a lot of work that is done behind the scenes to make sure. And of course, as I said in the outset, that these webinars are available on the YouTube channel. So once if you missed something or if you want to go back and listen to it, please go back. You are more than welcome to look at the YouTube channel. And then last, yeah.
Excuse me, my sincere apology. There is still a question left which was missed by me. My sincere apology. That is from Dr. Shakil. Why still the simulated patients are more popular rather than the simulated, even in North American OSCE? So over to you, Jabeen. So I'm sorry I missed this question, please.
Yeah, that's okay. And it's a very, very relevant question. Shakil, there is more simulated participants or simulated persons which are being used in OSCE, but I would say the trend is changing. There's a lot more happening where mannequins and other task trainers or other ways of simulation are being introduced to OSCE. I would say the reason being is being more comfortable with it. In SimKids, we do not have any simulated participants program or standardized patient program. We only ask for a couple of the scenarios where we need it. For example, there's a mental health crisis, code white, which is a angry patient or an angry participant. Code white is our code, which is called here. So for those scenarios, we use our simulated participants or patients. But yes, that is a very, very valid observation that OSCEs are more highly dependent on simulated participant, but the trend is changing. Even this year, year in the emergency medicine residency program examination, final examination with the College of Physician and Surgeon of Pakistan. The examiners, one of the examiner, Adil Khatri, who is I'm working very closely, has described that they have used many other forms of simulation in the OSCE. So the trend is changing. Stay tuned and you will see some differences. And I'm also closely working with the College of Physician and Surgeon of Pakistan to develop the simulation-based assessment systems in their major subject examination. So you will see a lot of change coming up in the next couple of years.
All right, excellent. Thank you so much. And again, I just want to, before we end, is thanks to all the participants who have so enthusiastically joined. And one more thank to Dr. JABEEN FAYYAZ is that she's so gracious in sharing her email and people can contact her. So that is, again, speaks to the fact that she's really invested in education. So thank you again, and inshallah, stay tuned for the next webinar in 2 weeks from now, same place, same time. Until then, take care, stay well, stay hydrated, and stay cool. And we'll see you, and Khuda Hafiz.
Okay.